So, I hope you already had a great lunch break, and then we will just go on with our next lecturer. But first, I want to tell you something about today in the evening. Some of you have already asked about the social evening, what it's all about. So we planned a social evening where we come together, all together, the tutors and participants, at 6:30 p.m. in the Two Brothers. It's the former office pub in the Trautmannsdorf Gasse here in Graz. And from 8 p.m. on, there's also planned how do we call it? Pub quiz, exactly. Thank you. So it's definitely a lot of fun, so maybe we will see us there. And so we get to the next lecturer. Our next lecturer is called Peter Zechner, and he studied in Graz, Tenerife and California. Currently, he is working at the LKH Graz West in the Department of Cardiology and Intensive Care. And sonography is essential for his working life. Today, he will give us an insight in the theoretical background of the RUSH concept. And after the hands-on session, he will continue with some interesting clinical cases. So, please welcome Peter Zechner.
Yeah, hello everybody. I hope you can hear me well. I'm sorry for not being closely to you, but this has several reasons. I don't want to talk further about that. Yeah, thanks a lot to everybody also who is watching the live stream on YouTube. And I also want to say a big thank you to the group of Sono4U for inviting me once again to this great meeting and also for the great organization. I think this meeting is an absolutely standout meeting and unique all over the world. So congratulations and keep on working like that. My today's topic is the RUSH protocol, which I named Detect, Treat First, What Kills First. My name is Peter Zechner, as my colleague told you already. I'm a cardiologist and intensivist, and for me, emergency ultrasound POCUS in general is a tool I use almost every day. For me, it's the most important tool, and without that, I would have big difficulties to diagnose and treat my patients accurately. You guys are in a happy situation because within the past 10 to 20 years, there was a big technical progress. So you guys have now a lot of very small ultrasound machines that are available almost in every emergency department, in every ward round. And you can take these machines to the patients. And this is a very, very big advantage because we save time and we can repeat our examinations very, very often and bring the probe to the patient or even to the accident site if we do it pre-hospitally. My today's talk is about the RUSH protocol. What does it mean? It means rapid ultrasound for shock and hypotension. Generally, I'm not such a big fan of ultrasound protocols. I use my own protocols within my head, and I use ultrasound more or less as an implementation into the clinical examination, and I use the probes and the scanning of the organs more in a way which organ is most likely to be the cause of an acute problem, and this is how I do it. But I have to say that for beginners and for young persons that are coming in touch with ultrasound for the first times, it's very, very useful to keep on using protocols because they guarantee that you don't forget anything. But of course, we can mix them all together, and within the next years during your clinical career, you will find your own way how you deal with all the protocols and the ultrasound. We're talking about shock, undifferentiated shock, and in more severe cases about peri-arrest situations where it's close to death. If we look, we can see that many of potentially reversible causes of undifferentiated shock or peri-arrest situations can easily be defined or excluded by ultrasound. First of all, hypovolemia, pericardial tamponade, massive pulmonary embolism that causes shock, tension pneumothorax, and low output syndrome that occurs acutely can be easily diagnosed or excluded by a focused ultrasound exam. How we can do that, I will show you later. I don't want to talk too much about shock in general. You can read it up everywhere in every textbook or in the web, but a few words about the different types of shock. There are 4 types in general. We talk about distributive shock, cardiogenic shock, obstructive shock, and hypovolemic shock. Distributive shock is normally caused by sepsis or anaphylaxis. In these cases, we have a normal cardiac output, a normal left ventricular systolic function, but the vena cava, so our pool of blood, is normally empty because of the distribution of our blood and fluid volume within the body. In cardiogenic shock, normally it occurs due to acute myocardial ischemia or acute cardiomyopathy. We see a low cardiac output and a reduced systolic LV function. In obstructive shock, mostly pulmonary embolism, pericardial tamponade, and tension pneumothorax, we normally see also normal systolic LV function. In pulmonary embolism, of course, the RV function and the RV size are not in the right way it should be. RV size is dilated and the RV function is normally reduced. In pericardial tamponade, even the RV function can be normal or should be normal. Even so in pneumothorax. In hypovolemic shock, we see a low cardiac output, but we see normal or even hyperdynamic. I will show you later what it means to be hyperdynamic left ventricular function. If we take a little look into the literature, and also my clinical experience says the same, we can see that the implementation of bedside ultrasound helps a lot to reduce the diagnostic uncertainty in undifferentiated shock. So if we use ultrasound in a very early stage in shocked patients, it helps a lot to know what the cause of shock is. So you should always use it if you have a critical ill patient. The RUSH protocol divides the body into 3 groups. First of all, the pump, which is our heart, then the tank, which is the vena cava mostly, which correlates to the preload, and then we have the pipes, which are, in this case, is mostly the aorta. Some people, when talking about the RUSH protocol, also use the name HIMAP. HIMAP is something you can easily remind you. It means high mean arterial pressure, and it means that we first have a look to the heart. If there is pericardial effusion, how about the global ventricular function? How about the right ventricular? Then we look on the inferior vena cava. Is it collapsed or is it full? Then we have a look for Morrison pouch, if there is free fluid, what you already learned within the FAST exam. Then we have a look onto the aorta, A for aorta, if there is an aneurysm or a dissection. And last but not least, P for pulmonary, we exclude or diagnose pneumothorax. What are our scanning positions? For me, the most important cardial scanning position in shocked or critically ill patients is the subcostal view. This is the subcostal position. Within this position, we can mostly generate very well pictures, and we can answer most questions that we have to answer in emergency situations. If we don't, if you're not able to acquire good pictures, we can also move to the parasternal long axis or short axis and to the apical for chamber view. The lungs we examine in the right or left anterior chest wall. Then we do the fast exam, Morrison pouch and collar pouch, and an oblique view above the gallbladder. And then we make the aortic slide view where we scan through the aorta. What are the clinical questions? We want to know, if we examine the heart, if there is massive pulmonary embolism, if there is pericardial tamponade, if there is hypovolemia, or if there is severe low output syndrome. Then we exclude a pneumothorax. We look for free fluid within the peritoneum, and then we exclude or diagnose an abdominal or aortic aneurysm. A few words to the different scanning positions, but I think I can go through it very quickly because yesterday in the anatomic part, you heard a lot about that. By the way, it was a great talk. Subcostal view, the probe is positioned subcostally, and then we see the heart as follows: the right ventricle near the liver, the right atrium, the left ventricle, and the left atrium. If we tilt the probe around 90 degrees and sweep a little bit down, you will see it in the practical stations. We can image the inferior vena cava. The inferior vena cava can be dilated, as in the right view, and full, like in case of obstructive shock, pulmonary embolism or tamponade, or also in cardiogenic shock, reduced LVF or RVF. And in cases of distributive or hypovolemic shock, we see a totally collapsed vena cava, like in this part of this M-mode movie here. The parasternal long axis, we can see the left ventricle, left atrium, aortic valve, mitral valve, and the right ventricle. If we turn the probe around 90 degrees, we have the parasternal short axis. Here we can see the left ventricle and the right ventricle. The left ventricle is round and much bigger than the right ventricle, at least in normal cases. The apical four-chamber view we can also use. Here we can see the left ventricle, the right ventricle, and left atrium, right atrium, and here the mitral valve. So far to the backgrounds and scanning positions. Now we start with the relevant problems and diseases, and also how we can diagnose and treat these diseases. First of all, I want to talk about pericardial tamponade. My preferred scanning position is the subcostal view. If I don't get good images, I move to parasternal long axis, short axis, and apical four-chamber view. Mostly apical four-chamber view is better than the parasternal axis views. What do we see in case of pericardial tamponade? We see echo-free fluid around the myocardium. First, we can see it in front of the right ventricle, later circular or in front of the left ventricle. It leads to compression of first right atrium, right ventricle, left ventricle, and then it causes shock, pericardial tamponade. Clinical signs are hypotension, tachycardia, and general shock symptoms. Here are some examples. This was a patient with a very big pericardial effusion. You see the hypoechogenic black fluid around the heart. The heart is jumping within this pericardial effusion. We call it the swinging heart. This is a sign of beginning or already existent pericardial tamponade. If we see such an ultrasound image in a patient that is in shock, it's very, very likely that this pericardial effusion is the cause of shock. And if this patient goes into arrest or peri-arrest, we have to think about how we can treat this situation. It's very important to mention that the amount of fluid is not alone the indicator for tamponade or not. It's more the time in which the effusion occurs. In some patients where the effusion occurs very slowly, we can sometimes puncture 1 or 2 liters of pericardial effusion, and these patients are stable. If it occurs very, very acutely, sometimes 200 milliliters are enough and the patient is in tamponadic state and in shock. Here another example of a patient I had to treat some years ago. You can see the liver here the heart, and around the heart we see circular fluid, in this case also causing tamponade. This patient was in shock and had to be treated within the next few hours at least. Also, this was a patient which presented in shock. It was a patient with an acute coronary syndrome that underwent PCI and had a coronary perforation which caused pericardial effusion, and 5 minutes later, even this small pericardial effusion caused severe shock, and we had to treat it on site immediately. What we have to keep in mind, if a patient goes into cardiac arrest and has pericardial tamponade, the mortality without treatment is almost 100%. If we treat this patient, the survival can be bigger than 0%. So we should think about it. How can we treat these patients if a patient goes into cardiac arrest and has pericardial tamponade? First of all, I want to show you how I normally treat pericardial tamponades. It's pericardiocentesis, needle puncture of it, and insertion of a catheter in the pericardial space. We do it from subxiphoidally or apically, depends on where we can see the most prominent pericardial effusion. It's not so difficult. I don't want to encourage you to do it in a patient that is stable, but if a patient goes into cardiac arrest or is on the way to go into cardiac arrest and you are far away from the next cardiology center, then you have to think about doing this procedure. Here you can see the scanning position. This patient was critically ill, but more or less stable, so we had some time to do this reading. Normally, I can do it much quicker if necessary. Okay, this was the scanning. We see the pericardial effusion around the heart. Everything getting prepared. Little incision. Now I puncture with the needle under aspiration in the same direction as I positioned my scanning probe under the chest wall. Here I aspirate bloody fluid. This was a patient with a with a bloody pericardial effusion. We checked it and inserted some microbubbles, but during CPR or in cardiac arrest, we wouldn't do that. I insert a guide wire, remove the
Das kann natürlich kein eindeutiger beweisen, aber es schaut eher nach was sehr
and then I check once again the guide wire position. You can see the guide wire within the pericardial effusion. And then a sheath is inserted over the guide wire is removed. Then we can aspirate all the pericardial effusion easily. So the same can be done from apically, but I think it's not necessary to show it here once again. Yeah, you can see now I aspirate the fluid, the patient is getting better, and then everything is going to be removed. This is the same, just in a few seconds. You can see where I put my probe. The same position.
So, jetzt kannst du noch mal ein bisschen trennen, gell?
Aspirate fluid, insert guide wire, over the guide wire, again a sheath, infusion is treated adequately. Here you can see how we use the pericardial. That's it. Of course, we wouldn't do it if not necessary, but if necessary, don't be too much afraid of doing such an intervention if necessary. Of course, in trauma patients, sometimes pericardiosynthesis is not the right way to remove pericardial blood. And in these cases, some people do resuscitate thoracotomy. I've never done this, but I just want to mention it, that it is possible to also do it at the open heart. So far, so good about pericardial tamponade. Next, we talk about massive pulmonary embolism. If we take a little look into the guidelines, we can clearly see that echocardiography is the first tool that we have to use if the patient is in shock or hypotension. We do not do a CT angiography if not immediately available within the emergency department. So first we do echocardiography, and if there is a sign of RV overload and the patient is unstable, we treat the patient with thrombolytic treatment. The scanning positions, we can use the same as I showed you before. Subcostal views, apical for chamber views, and even parasternal short and long axis. What we can see, sorry for this, there is a mistake, it's in German, sorry for that. We see a dilated RV and a compressed LV. We see a hypokinesis of the right ventricular free wall. We can see the McConnell sign, which I will show you later. We can see the D sign, where the septum is compressed by the overload of the right ventricle, and we can also sometimes see thrombotic material within the right heart. Here we see the dilated right ventricle and the compressed left ventricle. This is a maybe apical four-chamber view or even subcostal view. And here we can see that the left ventricle is very small and the right ventricle itself, it's very dilated. This is a classic sign of acute pulmonary embolism. So right ventricle is getting much bigger than the left ventricle and the left ventricle is compressed. Here, the peristernal long axis, we can also see a dilated right ventricle that compresses the left ventricle. The left ventricular function itself is good. Here a more severe case. This patient was already in cardiac arrest. This is a subcostal view where we can see a massively dilated right ventricle and the compressed left ventricle. Here there's only little motion of the left ventricle. This is the reason why this patient is already in cardiac arrest. This is the so-called D sign. It's called D sign because the left ventricle appears like a D. Here you can see the compression of the right heart, the right ventricle is compressing the left ventricle and the septum is compressed by the pressure in the right heart. So the left ventricle, which normally in the short axis view peristernally appears round shaped, here is shaped like a D. D sign is a classic finding in acute pulmonary embolism. Last, the McConnell sign. I told you before, you can see two views acquired from apical four-chamber positions, or this view maybe also from subcostally. We see a massively dilated right ventricle in both cases. And what we can see that only the apex of the right ventricle is contracting, whereas the free right ventricular wall is not contractile. This is called McConnell sign, and it's very typical for acute pulmonary embolism. In some cases, we can even see some thrombotic material here within the right atrium or here within the pulmonary arteries. Next, we talk about the low output syndrome. Same scanning positions can be used as before. And I show you some videos to recognize patterns that are normal or severely abnormal. Here you can see a peristernal short axis view. You see the right ventricle, the round shaped left ventricle, which is contracting pretty well. This is a normal systolic LV function. And here in this case, we see a severely reduced LV function. You can see the myocardium of the left ventricle is not really contracting. And if this patient is in shock, it's pretty likely that acute cardiac failure is the problem of this patient. Here, apical four-chamber views of a normal systolic LV function. You can see the left ventricle here. You can see the heart is contracting pretty well. And in this case, the heart is not contracting normally. It's severely reduced. The ejection fraction in this case is maybe 15%, so absolutely abnormal. And this is what I want you to recognize, the normal pattern and the severely reduced pattern. Other example from subcostally, here normal ejection fraction, the myocardium is contracting pretty well. Here a not so beautiful image, but you can see the LV function of this heart is severely reduced. Another example apical forward chamber view, severely reduced LV function. You can see the myocardium is not really contracting. And also in this view, from subcostally, this is the right ventricle, left ventrically only seen until the mid part, but you can see there is not a lot of contraction of the myocardium. In discrepancy to highly reduced ventricular function, we can also see hypercontractility. This can occur in some cases, for example, in septic shock or in hypovolemic shock. So if you see a patient where the myocardium is contracting very, very well, even better than normal, and the muscles are kissing, so all the blood is ejected during the systole, this can be a sign of severe hypovolemia or distribution problem, as in septic shock. But there are also cases of cardiogenic shock that can cause severe cardiogenic shock, but show a normal or even hypercontractile LV function. For example, acute mitral regurgitation or acute aortic regurgitation. I just want to show it to you as a pitfall. Just keep it in mind. It's not so frequent, but sometimes these findings can be misleading. This is an example of acute mitral regurgitation and the normal, even hypercontractile left ventricle. Here you can see the severe mitral regurgitation. And this patient is, of course, in cardiogenic shock and has a low output syndrome, although his left ventricular function is normal or even hypercontractile. Let's talk about pneumothorax. Just a few words, you will hear it later on more in detail. We scan the anterior positions of the left and right anterior chest wall, of the left and right anterior chest wall, yeah. The patient should be in a supine position, and then we scan the third or fourth intercostal space in the medioclavicular line. The normal finding that we can observe then is the so-called lung sliding. You can see these little points moving left and right with every breathing motion of the patient. And if we apply an M mode, we can see the so-called seashore sign. Even in the FAST protocol this morning, you heard about that, I think. Some examples of a pneumothorax. In this case, this is the pleural line, and you don't see any sliding of the visceral versus the parietal pleural. So it's abolished lung sliding, and this is a sign of pneumothorax. Left, normal lung sliding. Right, no lung sliding. This side has pneumothorax, this side no pneumothorax. This is the so-called lung point. Maybe you heard about it in the FAST exam. On this image, we can see in the same image, abolished lung sliding and normal lung sliding. If you find this lung point, the pneumothorax is almost 100% diagnosed. Let's talk about free fluid hypovolemia. For these questions, we use the FAST exam. You heard about it a lot today, just a repetition. This is the Morrison pouch, normal finding. In this case, we see free fluid within the Morrison pouch. If a patient is in shock, even a non-trauma patient can have acute bleeding. For example, ectopic pregnancy or something like this can cause shock and free fluid within the peritoneum. And if you find this in such a patient, this patient has to see a surgeon very urgently. Another example, normal collar pouch, no free fluid. Here you can see a little amount of free fluid around the spleen. These patients, if they have free fluid and are in shock, normally show signs of hypovolemia, like hypercontractility of the left ventricle and totally collapsed vena cava. Like here, you almost cannot image the IVC. AAA means abdominal aortic aneurysm, just a few words. It's not so frequent, but we should also look for it if we do not find any other causes of shock. Here you can see an oblique view in the abdomen where we can see here is the spine, this is the aorta, this is the vena cava inferior, and this is the aorta. Here, the aorta is normally dimensioned, maybe 2 centimeters in diameter, until 3, it's normal, but normally if there is a big aortic aneurysm, you will see it very easily. Like in this case, this is a classic abdominal aortic aneurysm with a diameter of maybe 5 or 6 or 7 centimeters. So if you see this, you should think about transferring the patient to a surgery department. So what should we do depending on our findings in a patient with undifferentiated shock? First of all, if we apply the rush protocol, we look for tamponade. If there is pericardial tamponade and the patient is in severe shock, we have to think about pericardiocentesis. If the patient has signs of massive pulmonary embolism and is in shock, the treatment of choice is thrombolytic treatment. If the patient is hypovolemic and has free fluid in the abdomen, think about surgery and apply some volume. If the patient has a tension pneumothorax, thoracocentesis is the treatment of choice. And in severe low output syndrome, we can apply inotropic treatment. If the patient has AAA, abdominal aortic aneurysm, surgery is mostly the treatment of choice. So this was my talk about the background of the rush exam. And I'm very thankful that you all listened to me. And yeah, if you have any questions or any other things you want to talk about it in shock patients, just let me know. I'm here for you. And later on, we talk about some cases, okay? Thank you.
Are there right away some questions to Dr. Zechner? No, so for now everything seems to be clear. Thank you, Peter, for your interesting lecture. And so we will have some hands-on sessions going on till 4:30 p.m. And we still have lots of good fruits and cakes out there, so if you just need some box stop.
Und jetzt weiter mit ihm. Dann 16:30 ist die Käse. Super, danke.